Welcome back to episode 2 of our discussion on racial trauma and culturally affirming clinical practice. In our first episode, we explored what racial trauma is and how it differs from traditional trauma, and how it can influence identity, parenting, education, healthcare experiences, workplace interaction, and therapeutic process. We challenged ourselves to recognize that many of the behaviors we observe in our clients may not simply be symptoms, but they may be adaptive responses to chronic experiences of racism, discrimination, and historical oppression. Today, we're answering the next question, and perhaps the most important question. Now that we recognize racial trauma, what do we do differently as clinicians? Is cultural competence enough? Or must we move beyond simply understanding culture towards creating a therapeutic environment that is culturally responsive, affirming, and psychologically safe? How do we build trust with clients whose lived experience may be very different than our own? Can clinicians effectively work across racial and cultural differences? What role do humility, curiosity, self reflection play in fostering healing? And how do we ensure that we are not unintentionally reinforcing the very systems that have contributed to our clients' pain? These are the questions we'll explore in this next episode as we examine what it truly means to provide culturally affirming care. We'll also begin introducing storytelling as more than a therapeutic technique. It is a culturally rooted practice that honors lived experiences, restores identity, and creates a space for healing. Let's continue the conversation. So this is what's interesting to me. Let me throw this out to you. So when we talk about, because I'm on this thing about cultural competence, I'm
Yes.
just feeling like it was that thing that we threw out there that says, "Hey, we addressed it."
Yeah.
Right? And let's look good at we're looking good, and we're appropriate because we're meeting everyone's needs, right?
Yes.
So, cultural competence, the primary focus is knowing and understanding, acquiring a toolkit of different cultural norms, beliefs, and practices. Culturally responsive and affirming is doing and validating, is doing the work, right?
Absolutely.
And I love the validating, because validating, you can't do the work without the knowledge, right? And the understanding and putting yourself not in the what is it? Not you're not the expert,
Yes.
right?
Exactly.
You are part of the learning experience
Yes.
of that individual, right?
Yes.
And so creating that safe space removes you from being this expert, and help you, help me help you by teaching me and giving me an understanding, because all cultures aren't the same,
Absolutely.
right?
Yeah.
And so, cultural responsive, doing and validating, taking the tools and applying them to meet the unique individual's needs.
Yes.
So it doesn't say that, oh, because we're all Black, I'm going to treat all of y'all the same. I remember, oh my goodness, and I don't know if you had this happen, but I've been to a store and someone would be like, hey, homegirl. And I want to clutch my make pretend pearls. Like, don't go there. I'm not your. Right. And why would you assume that I'm somebody's homegirl? Right? So I think it's so cultural competence
Yes.
or affirming isn't thinking that I can talk my way in it. Really, I think it's the opposite. It's really about sitting and listening.
Absolutely. Understanding at its core.
So the mindset of cultural competence is, I understand your background. The mindset of cultural responsive is, and affirming is, I see you, I respect your experience, and I will tailor my approach to support you.
Absolutely.
The action. of
Yes.
cultural competence is understanding cultural differences and to avoid disrespect,
Mm-hmm.
right?
Absolutely.
Understanding cultural differences to avoid disrespect. Okay.
Yes.
Cultural affirming and responsive is actively supporting and elevating the cultural identity without judgment or what's that word? Without stigma.
Stigma. Yes, I thought you were going there. Yeah. Yeah.
Right.
Yeah. Yeah.
So I really feel like we need to really lean more on
Mm-hmm.
creating that culturally responsive and affirming space, which
Yes.
will inadvertently create a safe space for people to be seen and heard.
Mm-hmm.
And as clinicians, I think it goes back to what you're saying is
Mm-hmm.
we've got to recognize that we've got to do the work,
Yes.
right?
Mm-hmm.
And maybe if we don't come in as though we're the expert in the room,
Exactly.
but we come to know, to seek the knowledge of the and understanding.
Yes.
And that goes back to you, Teray.
Mm-hmm.
Can a white clinician be culturally affirming? Historically,
Yeah.
and again, I'm not painting this with a broad stroke,
Right.
but if we're honest,
Yeah.
if we look at all the theories that we had to learn in school, those theories one was not about us.
Mm-hmm.
When we talk about cognitive behavioral theory,
Mm-hmm.
when we talk about
Yes.
our theories,
Mm-hmm.
right?
Mm-hmm.
If I can think of the theories, huh? Yes.
REBT. Yep.
When we talk about these theories were really focused on family systems theory. It was focused on the white man.
Mm-hmm.
It was focused on the white population.
Yes.
And so we're learning tools in which we have to augment.
Mm-hmm.
We have to change to meet the needs of the culture in which we're working with. And so that's a biggie.
Yes,
A
it
lot
is.
of and I loved it because the APA, the American Psychological Association, um, uh, openly apologized because it didn't give space for individuals in the Black and Brown community. A lot of the approaches were tailored towards the white and the white families,
Yes.
and then we got to do the extra work to say, how can we apply this?
Yeah.
Right? How can we apply this to the indigenous population?
Mm-hmm.
How can we apply it to the Hispanic population?
Absolutely.
Stop forcing people to always look people in the eyes or override their family structure when their family structure was a part of their culture.
Yes.
Or stop, and stopping. And this was one big thing that happened when, that was really prominent when I came into this field was that, oh, you can talk about spirituality. But if spirituality is a part of one's culture,
Mm-hmm.
why can't I talk about it while we're still billing insurance?
Yes.
Right.
But that was a no-no.
Really? I've never heard of that. That's an interesting
Yes,
thing. Wow.
yeah. I've been around for a little bit.
Yeah.
So it
Wow.
wasn't a and then it emerged into let's ask permission. If an
Mhm.
individual wants to use their spiritual beliefs within their therapy, they can.
Mhm. Mhm.
But what was interesting is that there wasn't permission for people to use their cultural beliefs. There wasn't anything outside of, oh, we got cultural competence, which says, I know where you're coming from.
Mm.
Right.
But who has once said, let's talk about your culture
Mhm.
and what that means to what you've been through
Absolutely.
and how that impacted
Mhm.
what you're experiencing.
Mhm.
And let's take it a step further to our Black and Brown, to our indigenous population, because of course, just like we could talk about slavery, we've got the Trail of Tears, we've got a lot of cultural trauma that has happened to so many, right?
Yes, we have.
So how do we bring that into the room?
Mm-hmm.
as a clinician.
Mm-hmm. Yeah. I think you always address the elephant in the room. You call it
But
out.
don't we have to acknowledge that that's an elephant in the room?
Yeah, and I think we do have to acknowledge it, right? And that goes to the point, right? I do think we need to speak about it with our clients and educate ourselves as well and immerse ourselves in what the client has experienced to some degree to catch us up if there is a knowledge gap because we can't
Right.
know everything.
So to go back,
Mm-hmm.
can a Caucasian, male or female, effectively treat an African American, male or female, if a part, and can they recognize
Mm-hmm.
racial trauma within that individual or the historical atrocities? I mean, of course, we could all acknowledge these things happen, right?
Mm-hmm.
But can they see that it's showing up in their lives,
In their lives or in their
in their
clients?
clients' lives?
You know, it's an interesting question because I think the question can be reversed as well, right? So that's just me saying, can I work with a client that's from um, like a Chinese background? Or like, can I work with someone who is from a Hispanic background or a Caucasian background? Do I have the knowledge? You know, do I know what it feels like to have a history of being labeled as the oppressor? And then trying to make meaningful relationships with those you've oppressed, right? So that's also an experience that I'm not privy to, that I haven't lived. But can I still walk with a client through that lived experience if they have that? Because that are some of the biases that the Caucasian race experiences also.
Yeah.
Although they may not be those who are perpetrating it today.
Exactly, exactly.
So I do think the question can be reversed on both sides. I think it's a level of willingness from the clinician, training of the clinician, and openness to really address, okay, what am I sitting with as an individual? What comes up for me when I sit across from this individual? And let me address that. And maybe some of that I can address in the session with the individual for better understanding.
Right.
But then part of that, I might need to do my own work.
Do my work, do my work, do my work, whether it's clinical supervision,
Yeah,
whether it's looking in the mirror, right?
absolutely.
Whether it's studying to show that thyself improve,
Mm-hmm.
right? But I am a big one for
Mm-hmm.
understanding that individual's experience and knowing that
Mm-hmm.
I am not the smartest one. I don't have to be the smartest one in the room.
Mm-hmm.
Even though you've come to me,
Yes.
you are the expert.
Mm-hmm.
I'm just here to take this walk with you. And
Mm-hmm.
I think, and so to answer, I do believe it's possible.
I think it is. Yeah.
I think it's possible for people to show up for people if they're willing to see that person for who they are and for what
Mm-hmm.
they have gone through and remove yourself
Mm-hmm.
from that experience, right?
Yes, and I want to mention that I think it would be a very powerful dynamic, right? Because to sit across from someone who is very different than you and feel validated and seen and heard can be a very healing process if done
Yes.
in the right way. So I think it offers a unique experience if both parties are, like agreeing into, taking that walk and knowing that it's going to be very sensitive. But I think it could be very powerful and transformative.
So, what would we say? What would we say to clinicians who are saying, you know what, I don't want to be a part of the problem,
Mm-hmm.
right? And I
Exactly.
want to learn about an individual's lived experience when it comes to their culture or their trauma that they, and I don't want to, I don't want to continue to hinder their
Mm-hmm.
healing by not being able to see. What would you say, what would be some of the things that you would suggest that they start to work on or look at? What do
Mm-hmm.
they need to do?
So for me, I think it's exactly what you just said. Literally what you said in the session with the client. It is totally upfront. I believe in that. I believe in addressing things upfront and letting them know I do not know everything about your culture. I understand that you are a total person. There are multiple facets of who you are that may be playing and showing up at this time. I want to learn. what those are. To be respectful, correct me when I'm wrong, let me know what I need to look into so that I can better understand your experience. And I will do that in honoring the therapeutic relationship. Because you would do that for someone that you value, you care about. And that's how you build rapport. That's how you build the safe place that we're talking about.
Yes.
It's showing the effort and being open to also facilitate and be an example of the relationship that you want them to develop with other people. So again, I think it's powerful to do that, but you have to remain open.
Yeah, I agree with that. And me being a pretty new clinician, therapist, and that's something that I do in all of my sessions. I always tell my clients, hey, always correct me if I'm wrong. I'm never telling you that anything is a definitive thing, right?
Yeah.
But we're just here to talk through it and process it and figure it out and see what works and see what sticks and see what doesn't, right? We eat the meat, spit out the bones, and we're doing both of us are doing that together. And I also always tell my clients the reality is I'm here for 50 minutes out of your entire week, right? And sometimes 2 weeks or a month, right? So there's no way that I could completely understand and all. So I preface that a lot of times in sessions as well, and I'm like, I'm what is most pressing to you. I don't want to assume, like, tell me what what you want to work through in this time that we have, because I don't know, right? I'm never telling them that I know anything about their experience, no matter what it is. If it's racial, if it's cultural, if it's career, if it's whatever.
Yeah, that's so validating too. It just opens the space up, right? I really believe and creates that space that clients crave, which is non-judgment. And so in society, this racial bias that we're talking about, the racial trauma that we're talking about, I think there's a level of judgment that's under that, right? Those are those biases that we have.
So I want to jump because I feel like I kind of moved us a little ahead, but I want to go back because I like, and maybe we're right where we need to be, because you talk about judgment, right? Because if I were that white female therapist that grew up in my privilege, and I'm looking at a different culture, and I would have questions too, right? And so one of the things that I need individuals to understand is that, if we talk about what's against a race, right? What happens when we have racial trauma? What happens when we create these systems that have been placed to subjugate a whole a whole culture, right? And so of course, you brought up slavery, right? And that has its effects, right? And we talked about the working harder, and in that mindset, we were reinforced that we were labor and we had to work harder, right? Then we talk about the Jim Crow segregation, right? Where you stay on your side. I remember living right here in Milford, right? And I was on Northwest 2nd Street, and all I wanted to do was wish I could live over by, over in this area. We were grouped over there. Now, I didn't know that was at one time, people that were older than me talked about the dividing line. So there is a reality here that I can remember Benjamin Banneker. We had a black principal, and we had, and it was majority black students, right? And I remember that they were busing. Even in the 70s, they were busing to try to provide more integration, because Benjamin Banneker was known to be the black school, and you had Lula Ross, right? And I never went to Lula Ross. I always went to Banneker. But I can remember more white kids over the time coming there, redlining, right? Not even able to buy in certain neighborhoods, right?
Yes.
And we can say, and you're right, people can say, but that's in the past. But is it really?
No.
Right? Like, I mean,
Still very present.
it's very present in so many different ways.
Yes.
Right?
Mhm.
And so, housing discrimination, mass incarceration.
Absolutely.
Everybody is not trying, every black male is not trying to go to prison.
Mm-mm.
And every black male isn't trying to commit crimes.
Absolutely.
Sometimes the only crime that these individuals are committing is being black.
Yes.
Educational inequalities,
Mm-hmm.
right? Yeah, pipeline to prison.
That's the same.
Medical racism.
Mm-hmm.
We still deal with the effects of how medically we were either not provided the same level of care,
Mm-hmm.
or we were experimented on
Yes.
in so many different ways, in which you cannot, you got to understand where that individual's coming from if they don't believe in the medication that you're giving them, or they question the approach, right? Or we want to push, why are they not coming for treatment?
Yeah. And again, that's not just a black thing. It's a black and brown thing.
I mean, we're
Yes, it
steady learning.
Yes, it
I mean,
is.
come on. One of the most famous is the Tuskegee experiment,
Yes,
right?
absolutely. Mm-hmm.
But it's so much more than that. I mean, if the post-traumatic, you ever heard of post-traumatic slave syndrome?
I have. I believe I have.
I haven't much.
Dr. Joyce DeGruy, she post-traumatic slave syndrome, and she talks about the different experiments that OBGYNs, they didn't, the doctor did not anesthetize, did not provide it. They just would do the surgery or deliver
Yes.
the baby without any anesthesia or anything.
Yeah, the idea that we could handle pain or pain tolerance was much higher than others. Yes, I've heard of that. Mm-hmm.
And it was so many different experiments that they would, and they would use tools that were not cleaned, or so the whole mindset
Yes.
of what we could tolerate, or not being a full human, those things carry from one generation to another. And even though we might receive a lot more humanity than what we did, it's still there.
It's still present.
There's so when we talk about historical trauma, that's what we're talking about. When we talk about racial trauma, that's what we're talking about, because it has the racial component, but also it is historical. And you're right, it is beyond just a black thing, right?
Yes.
And so the impact has created wealth disparities, missed educational opportunities, neighborhood, resources. We've got gentrification now, which, is it a good thing or is it a bad thing? Right? Like, you see, I mean, if West Rehoboth is a whole idea, that's a whole gentrification.
Yes, it
right?
is.
Absolutely.
Yes, it is.
Rehoboth in general, they're stopping more low income, units and things being built down there. The people are rallying against it, and that's why we're having an issue down there. People, that's why they can't fund business. I mean, run businesses and things like that, because people that can't even afford to live there. But you're actively pushing against that. It is.
So African Americans, today's experience cannot be separated from the historical experiences.
Yeah, no.
It becomes a part of the generation, just like we understand that alcoholism can connect from one generation to another. Being born out of wedlock, right? Having births at a very young age. These things, living in domestic or experiencing domestic violence within our homes, molestation and rape, all of those have historical impact from one generation to another. So if those have historical impact, why would not racial trauma have the same type of impact? we're still trying to make up for it. We're still trying to figure out how to survive through it. And
Yes.
so that stuff is going to show up in
Mhm.
our schools.
Absolutely.
That stuff is going to show up in our workplace.
Mhm.
That stuff is going to show up even in our sessions.
Yeah.
And we have to be prepared and we have to slow down and acknowledge what this person is bringing to
Mhm.
the table.
Mhm.
And not from our view, but from their view.
Yes.
And understand as a clinician, maybe I do carry some bias.
Mhm.
Because maybe that individual that comes to me and said that they just got out of prison,
Mhm.
what negative connotation is connected with that,
Mhm.
right?
Mhm.
And how is that manifested in their treatment?
Absolutely.
Then we have this push, and I get this a lot. I don't know if you do. Oh, I want a black therapist. Or I've been looking around for a black male therapist,
Mhm.
right? I want someone to understand me.
Mhm.
And here we're being overworked because I love the ideal that our black and brown community are reaching resources, but at the same time, why are they keep reaching? Why are they just reaching out for us? What's happening to where they feel
Yes.
like no other individual is going to understand their experience?
Mhm.
In 2026,
Racial drama.
we
Trust.
still, because do you go and say, I just need a black doctor or a black dentist?
I would like to.
Yes. Absolutely.
If it was available, I would like
Yes, it's
to.
a preference.
But what is it? It's a preference. Is it because you feel like you're being seen,
Yeah.
It is.
understood?
It's the trust factor. Yeah.
It's multiple. It's those things for me, and also because I recognize that majority of us in these places we are just underserved in the way of being able to maximize our true ability. I want to support it. I feel like it gives them the opportunity, right, to be seen and appreciated.
Oh, you're talking about so that black doctor
Yes.
that or
Yes.
that, hey, no, I'm coming to you, I'm trusting you.
Yes.
But see, I think that a lot of people would trust, right? You don't think that that more people non-black would trust a black doctor?
No.
I think that they have second guess. I just like these racial biases that they have, right? I just believe that there's still this level of inadequacy that they may feel, no matter the title, no matter the education, right? So it's me seeing my counterpart and showing up for them. That's how I see it as well, in a supportive nature.
And we've seen that too. No matter the profession, pilots, black pilots. That was a thing.
Is that the
Right.
DEI higher?
Exactly. Are you
Oh,
qualified?
yeah.
We've seen that. Or we've seen people be actively racist and say, I don't want that black person touching me. Or that person of color. It doesn't necessarily have to be black, but we've seen that. That's a real thing.
So let's talk about something. You guys are going here with me, the micro level. How does racial trauma show up in society on a micro level?
Okay, so I guess if this is a good example of a micro level, but there was an example. I actually was with another professional. We are the same level. I say this in terms of education because I think this is really important to note, whether she recognized it or not. She was a white counterpart older than me. And so we see each other, we get into the elevator, and she's like, "Hey, sister." And I said, I was a little uncomfortable. I didn't know what to say. I said, "Oh, hello. How are you today, ma'am?" Trying to redirect the conversation for it to be more professional. But it was that feeling of entitlement that I felt she had to call me like sister, which is a name that is typically used with endearment within our community. Right. And not knowing her, having any type of relationship with her, I felt like that was a microaggression. And not only that, I will also note that this same individual asked me before she knew my name, "Hey, you work here. What's your education level?" That is definitely a microaggression. In my opinion,
Yeah.
it's prejudgment prior to even knowing who I am, why I needed you, what the context of the conversation was. You needed to know if I was even on your level, right? To even have a certain dialogue with you.
And you bring up some, because how, if you were going to your therapist, right?
Yeah.
And you would bring that up
Uh-huh.
to be able to talk about your experience. What are some responses do you think that you would get? Like, culturally competent, I can acknowledge your feelings, but what would a culturally affirming and safe experience look like for you who just had to experience that microaggression?
Yeah, I think it depends because it was very dismissive, I would say, about the education level. I think that is very triggering to what you had said, right? We're working 150% to even to be seen as equal, right? So to even to be asked that, I think it reinforces that notion that I need to continually prove myself,
Right.
right? That's maladaptive, right? So I would
Right.
need to process that.
Yes.
With my therapist, because that's not the way in which I would like to continue to operate
Right.
in that way, especially with that individual. So then, we would have to discuss that. But I think that's worth addressing.
I do. And I think what we should not do as a therapist
Yeah.
is to try to get you to see it any other way. I think what we should do as a therapist is to sit in that space with you
Yes.
and talk about what that experience was like for you, knowing what we know, that you are well educated, that you earned your space in the room, right?
Yeah.
I think what we have to do is stop trying to smooth things over and make people feel comfortable, but acknowledge that no, these are uncomfortable experiences, and sit there with our client to just recognize that. So what do you think your next approach should look like, and how do we prepare you to maybe handle her in the future, right? And whether you even, and let's even want to take that up the chain, right?
Yeah.
And I think that is a more culturally affirming and safe space, is to be able to allow someone to have that experience and not try to sweep it under the rug or dismiss it, or to say that you're too sensitive or what's going on with you that day that you felt that, because you're right. That, I mean, that goes back to my homegirl. I've never had anyone call me a homegirl, black or otherwise, right?
Right.
So why would you think that that would be okay for me?
Yeah.
And I mean, I really didn't like that. And you're absolutely right. And why can't I call it a microaggression?
Yeah. And why did I see it that way, right? And in journeying through that with the client too, what caused that response? Where did that response come from? Do you always respond in that way if you hear something like this? And really getting down to it, right? Because then you're really going to be addressing that trauma and where the root of the response is coming from.
Exactly.
Yeah. Because it's tied to a value that you have about yourself.
Yeah.
Right? So it's triggering that.
And why, of course, we cannot control what other people think or feel,
Absolutely.
but we can control how we respond and how we act, right?
Yes.
But how do we deal with individuals who become really, and I don't know, do I even want to, now that I'm sitting on it, is that even a microaggression, or is that aggression? To come and challenge me about my, my education
And
level.
it's a shot in the foot because I'm working 150% and still.
Right? That level of reinforcement is devastating to some.
And that's what this is talking about, that many clients begin to question their worth, their safety.
Exactly.
Right?
Yes.
Whether they're being seen, being heard, and their sense of belonging. Remember, somewhere along the line, I didn't feel like I was given a space to feel like that I truly belonged, right? So I created it. I had to create that space because I could not feel comfortable in being okay with you giving me even 10% less than my white counterpart. I don't think that was fair. And so I'd rather be over here and just figure out how to, I'm the one that
Yeah.
create the jute joint, right?
Mhm.
I'm over here helping Harpo, and we're gonna create our little jute joint.
Yeah.
I mean, but I had to
Yes.
because that was being true to me.
Mhm. Mhm.
But we've got to figure out how do we keep showing up for our clients,
Mhm.
right?
Absolutely. Yes.
And then how do
Yes.
we even create, advocate for them,
Mhm.
right? How do we advocate, especially when you're in a position, right? As a white clinician, could you be in a position to advocate on their behalf, right? I've sent letters and emails in support of my clients that need a little bit more care or approach. Like I mean, it is such a thing called trauma informed workplace.
Mhm. Yes.
But what's
Yes.
interesting as we talk about that trauma informed workplace, it was not including our race. It was talking about, yes, was it talking about meeting that person and what they've gone through, but it
Mhm.
did not specifically talk about that individual in regards to race.
Yeah. Sensitive. That's sensitive.
And so,
Mhm.
did I have to be aware that you might not like a dark space or loud noise, right? Yeah, I had to be aware of that. Or you
Mhm.
might not like you know, your pronouns may not be respected,
Mhm.
but who is there for me when I'm being questioned about my education?
Mhm.
Right.
And why is that not being seen as not a trauma informed workspace, right? Like that's traumatic
Mhm.
because now you're questioning whether I belong,
Yeah.
right?
Mhm.
So so let's go to the next because actually that is the micro, right? Like
Mhm.
that pilot
Mhm.
that that doctor,
Mhm.
not necessarily where did you get your education from, right? Where were you a DEI hire,
Yeah.
right? Then we have the mezzo. So now we're talking about family and community. How does racial trauma show up within our family? Now, I share with you about how my parenting, right?
Yes.
And how that approach really was based off of my own experiences,
Mhm.
but even in the community.
Absolutely. And how we interact with each other, how we trust each other, how we treat each other, how we support each other. Discipline also in terms of parenting. Racial trauma is embedded in that for a lot of families. And again, I can only ever speak for a black experience, right? But yeah, how we interact with each other as individuals, even some of the uh labels and things that are put on us as far as like I don't know, I can't really give a good example, but let's just say how we interact with each other in the community, black on black crime, that whole thing, right? And our internalizing that, right? That influences how we then interact with each other because then for some, especially when you're in a poor community, you're trying to survive or whatever, you might take on some of that. You know what I mean? Just because that label was placed on us or because those, you know, ideologies were placed on us. It interacts how it affects how we interact with each other as far as family or as community. That's just what I think of in terms of
Mhm. I think it does. Yeah. It plays a part for sure.
And so, and so for some of us, right, it was don't draw attention to yourself. That's what we were, in the community, right? Like keep your head down, make sure you come, for me, when my kids used to go out, don't forget you're black, right? I would say that in a minute. Don't
Yeah.
forget you're black. And one of my son's teachers had reached out to me because he had what my middle son had started driving, and she had reached out to me, and she was like, I read an article that said that if you put a baby on board or you put a teddy bear in the back of the Miss Clark, bless her heart, Dr. Clark now, but she said put a teddy bear on the back of his car so that they're less likely to be perceived as a threat. I loved her for that.
Oh, that was
White lady, like
nice.
it was beautiful that she would reach out to me to be like, hey, this is how we need to keep our boys safe. Right?
That's her leaning into that responsiveness that you were
Yes.
just talking about.
Yes. And so and it's there. So it
Yes.
is possible. And
Yes.
and again, this is not to say that every clinician is not capable. It's just to say
Absolutely.
let's talk about figuring out how to lean into it. Let's talk about getting out of our own comfort zone and recognizing we don't know what we don't know. I really don't think a lot of it is intentional. And if it is, then then hey, that's on you. But the fact is, the ones that really want to really take heed to what we're talking about will start to do their own internal work, right?
Yes.
And recognize that it's the work, and we got to do it together, right? Because even as a African American, I can't walk around act like I know it all,
Yeah.
because it's culture over here on the East Coast in Delaware is different than culture down south
Yes.
or in New York, right? Like it
Even in Philadelphia.
and even in Philadelphia, right?
Yeah, culture is different in every household. We may all be under one race, but our experience is different. And I think that's also why it's individualized, and it's important to take your time with each individual person and not generalize.
Yes.
Yeah.
So it goes back to what you said, which is we actually create protective factors based off of racial trauma within the families and within the communities, which create chronic stress, which takes us to that performance fatigue,
Yes.
which takes us to that 150% rule, and always having to figure out how to show up and show that we belong, right? Then we have the macro level, and that's where we're looking at education, right? We're looking at healthcare. We're looking at all these different dynamics. And so, one of my biggest concerns is African American males, being diagnosed with oppositional defiant when it really could be depression.
Yes.
When it really could be anxiety. It could be attention deficit disorder, hyperactive, right? Like it could be a lot of different things, but we quickly go to aggressiveness when we see someone, and it might look different, right?
Yes.
But every aggression isn't aggression. Every response isn't. And I think that's the part that we have to start to understand. How is this showing up, right? How is it showing up in the classrooms? How is it showing up in, in the healthcare? And who's being really dismissed or pushed along? And how do we, as clinicians, begin to just acknowledge their lived experience with that? So we've got those. So and I think we did a pretty good job at talking about what does racial trauma look like. We talked about it in the workforce. We talked about it in the community, in the families, and we also we talked about it in the office, right? Like I think what is the take home is to recognize that we've got to ask the questions. And we got to remove ourselves from being that expert and recognize that the client is the expert. Learn from the client. And and this is like my prelude for our next one, which is talking about storytelling, which uses narrative therapy, which is, again, narrative therapy narrative therapy is really focused on our white counterpart. But the augmentation of it is storytelling, is teaching individuals to use their lived experience to tell their stories, so that one, that they're not re-traumatized, but also to say it in a way that empowers them, but also the therapist to understand. It removes the therapist, it removes the clinical bias because it puts that client in the driver's seat of being able to tell their story.
Absolutely.
And so that becomes a culturally affirming tool that we can use when we're addressing racial trauma.
Mm-hmm.
Any questions?
Mm-hmm.
Any comments? I love the fact that I had you guys. It was great. I think we went through. I think we did
I
it.
feel like I caught myself in here listening a lot of times. Like, wait, there's so many thoughts.
It is.
Yeah.
But I feel like after doing this, we could sit in one area and just keep going.
You could.
Mhm.
You really
Yeah.
could.
But I guess the question becomes, do you think it was enough to get a clinician's attention?
Yes.
I think
Absolutely.
so. Yeah.
Absolutely.
Okay.
Yeah, it was a lot of good information. And I
Yeah.
think a lot of steps forward too. Like actionable steps that someone could take
Absolutely.
to apply it to change, right? How
Yeah.
they're showing up for their clients, or
Yeah.
even take a minute to consider how they're showing up for
I
their
was gonna
clients.
say,
Or if they're not, right? Yeah.
Yeah.
I was
Yeah.
gonna say, even just sparking the thought of,
Yeah.
oh,
Mm-hmm.
you know what I mean, and
Yeah.
it did for me while I'm sitting here listening.
So let me throw a few more out that just looking at this. So how racial trauma looks like, what racial trauma looks like in therapy. Hypervigilance.
Yes.
Right?
Yes.
Mistrust, we talked about.
Mm-hmm.
Anger,
Yes.
we talked about, right? Like, anger isn't always just anger. Anger
Mm-mm.
is and this drives me crazy. Anger is the protective, is the maladaptive protective factor for what? Depression, anxiety. We got to go and look deeper.
Mhm.
Stop having people work on anger, because if you work on the depression or you work on the anxiety, you work on the underlying issues,
Mhm.
then you will address the anger. Anger is just that response, that coping skill, right?
Yes.
Emotional numb.
Numbness.
Emotionally numbing.
Yes. Through substance use, right? Through addictive behaviors and tendencies, through poor relationships, through
Isolation.
avoidance tendencies, right? These are where the maladaptive behaviors start to kind of manifest. Yeah, definitely.
And if you know what I think about, that little girl or that little boy in school saying, I don't care.
Oh, yes.
It doesn't matter.
Oh,
Right?
yes.
They don't care about me, right?
Mhm.
And you just there. I can remember even myself sitting in school listening to history, and it wasn't about me.
Mhm.
It wasn't about me, just a small segment, and I detached.
Mhm. Oh, yeah. So
I
many times.
detached, and my grades suffer for it because, of course, it looked like I was lazy,
Mhm.
or I was defiant. I wasn't inability to learn.
Mhm.
No, you did not show me.
Yeah.
I didn't show up in those books. You didn't pull me in.
Mhm.
And if you did pull me in this was, again, I'm dating myself, but Black history
Yeah.
back in the day was a week, right?
Wow.
It was a week. And what we were here is the mainstays, right?
Mhm.
Like Harriet Tubman, Benjamin Banner, Martin Luther King, right? But we didn't show up. And so I think sometimes if we are being not seen,
Mhm.
not heard, not validated, we will become emotionally numb. Substance use. And then they talk about the somatic symptoms,
Yes.
right?
Mhm.
The headaches, the hypertension, the
Mhm.
gastrointestinal, the chronic tension. And let's talk about, and we got to sit on this misdiagnosis. We talked about little Hakeem being diagnosed with oppositional defiant disorder instead of, and little Johnny being diagnosed with attention deficit, right? Hakeem gets suspended and little Johnny gets medicated and put on an IEP, right? And so,
Absolutely.
And it is because what they don't know about Hakeem might be getting in trouble if he gets in trouble again, right? Hakeem may have maybe some frustration at the fact that he can't learn because, again, remember, especially if he was my child, it was that 150% rule, right? Like you had to do better.
The pressure.
It's so layered too, just like how you just connected that.
It is.
It's layered. Wow.
And so we don't want to see Hakeem really may not be aggressive. He really we might see anger, but what we might really see underneath is fear.
Yes, something that you mentioned I think is a great thing to mention. Anger being a secondary emotion.
Yes.
Right? We do such a basic understanding of anger as the iceberg, right? We all know that. So anger being the tip, that's all you see. You can't see how big that iceberg is underneath the surface. And underneath the surface is where it holds all of those residual emotions that are just being expressed as anger, because perhaps that's what he sees, or that's what has been emulated, or that's what's comfortable for him.
Safest.
Bingo.
Because I might not even be angry. Bingo. But you're looking at my behavior as if I'm angry.
That angry Black woman.
And I'm not even angry. I'm just not tolerating whatever.
Or that face, right? Your look, right? And how all of a sudden now I get this because of my look?
And that's their bias that we were talking. That's that generational racial bias that we were talking about, right? That unconscious at times, something that's been ingrained throughout generation to see something and perceive it in a certain way that perhaps it may not be for that individual.
So if I'm not showing my pearly whites, if I'm not smiling ear to ear, then something's wrong. And I'm aggressive.
Yeah. You're not performing.
Yeah.
Wow.
Oh, I'm being difficult.
You're not yourself today.
This is your true self. Oh. Wow, I've never seen that. I don't know how to take that. So that must be bad.
Or maybe it's just different. And what we have to understand is that everybody doesn't like different. That's why we're here in the first place. That's why we had to go through all of this, because it's the different that people become uncomfortable with.
The lack of control.
Not
like
too.
Yeah. It is so layered.
It is. I think it's a lack of control. You just don't. You don't have control of my space at this. You know what I mean? I feel like sometimes that can happen too.
And you don't get to define me.
Right. That's what I mean by control. Yeah.
And that, stirs up some feelings sometimes in the opposite person, right? That are not ours to take on. But I think, when we sit and talk about performing, we are trying to change the narrative, right? Sway it in our favor, because that's what we need for success. So I do think that plays a part, but
misdiagnosis. It's been known, and the studies show, NIH, CDC, APA has shown that African Americans are more likely to be diagnosed with some type of psychotic disorder, such as schizophrenia, bipolar, and any other conduct disorder, right? And we're more likely to be put on psychotropic medication.
That is
we
valuable.
have prescribers even to this day that will not see PTSD in an individual, because again, their bias is that Black individuals may not, because PTSD shows up differently maybe in a Black individual versus a white counterpart.
Yes,
right?
It does.
Because who can have you given yourself permission to walk around fearful? Have you ever given yourself permission to be fearful?
To be fearful, like to be afraid?
To be afraid. Have you allowed yourself?
To be honest, no. That's a very interesting question, and I would have to say no. I pride myself on actually not having fears. And
where do you think that comes from?
Well, I can say it directly comes from my mom, who is very fearful. So I don't like to live my life with restriction.
But when
Yeah.
there is a known experience in which
Mhm.
you can really validate that there's fear,
Mhm.
fear may look different in African American women, right?
Mhm.
Or men,
I
right?
can agree to
Fear
that.
can look like aggression,
Mhm.
right?
Absolutely.
Domestic violence situations. I can still remember reading
That's
and
so
doing
true.
this CU, and it was doing it on domestic violence, and they said that um, the highest percentage of PTSD, reported PTSD amongst any category of women was white Caucasian. Caucasian reported the highest rate of post traumatic stress disorder based off of domestic violence. And
Wow.
Black Americans were the least.
Hmm.
One, so it was reported, right?
Mhm.
Mm.
And so one, do we that tells me, do we always go and say something's wrong, or do I survive? I just survived through it, right? Like, do I
Yeah.
go to my therapist and say I think I have PTSD,
Mhm.
right?
If we go to therapy at all.
If we go to therapy at all, right? But then what's interesting is that when you went further into the CEUs, it said that we're least likely to report symptoms, or that we even have it. Which I wonder, did you listen? Did you listen? Did you, because everybody that comes to me doesn't necessarily say I'm coming in saying I have PTSD, right?
Right.
Mhm.
But as a trained clinician, we
Mhm.
look in the diagnostic manual, we know the symptoms, we know the
Yes.
criteria.
Mhm.
Could you see it on me? Could
Mhm.
you hear it by what I'm telling you? Did you ask the questions?
Yeah.
Yes.
Another thing to consider is that we tend to diminish some of our, symptoms, if you will. We don't call it. We don't feel like it is what it is sometimes. You know what I mean? Or we downplay it. So again, it's on the trained professional to pick it up.
And that means we've got to
Absolutely.
start training our
Mhm.
professionals to see people for who they are
Mhm.
and not what we think that they are,
Mhm.
or see people. And you cannot take these theories that we've been learning in school and
Mhm.
think that we're we can just apply them to everyone.
Yes.
They have to be augmented.
Mhm.
And we have to do a better job at starting to look at how do we augment these theories and these approaches to best suit each individual client,
Yes.
and stop thinking, oh, well, I've used this to do this, and this is, and this should be working. It's like me trying to do hypnotherapy on someone who just had a traumatic event, and
Mhm.
I'm telling them to close their eyes and trust. No, that's not
Mhm.
going to trust, right?
Absolutely. Yeah.
But yet we think that we can use these tools that really were never meant for these individuals,
Yeah.
and think that that's going to be able to sell well, or they're going to be able to
Mhm.
respond well. No, it doesn't.
Mhm.
And so we have to start to look at, how do we augment, how do we bring in their community, how do we understand their culture, right?
Yes.
And how do we start to develop new resources, and inadvertently new theories
Mhm.
that represent the population,
Yeah. Yes.
because we are changing, right? So racial trauma is not simply an individual problem. It's a psychological response to repeated exposure to racial stressors occurring across individuals, families, communities, and societal systems. As a clinician, our responsibility is not only to treat the symptom, but to understand the context in which those symptoms developed. In our next episode, you'll explore the cultural and historical roots of storytelling within African and African American communities, and examine why storytelling has long served as a mechanism for survival, resilience, identity, perseverance, and healing. Until then, remember that every symptom tells a story, and every story deserves to be understood within its cultural context. Thank you.